right, everyone, welcome back. Thank you for that, bearing with us for that short break. We have all of our wonderful speakers here. Lots of great questions coming in from the chat, but we also have a lot of interested listeners here today. Was going to open it up first to the audience members with any questions you guys have for our panel members, and then we'll take questions from the chat and intersperse those.
Thank you all for such great talks. Dr. Matu, this question is for you. I know that we cited some great literature in terms of the cutoff for vtac and what is not vtac. What is your cutoff?
I use 120s to 130s, probably 130.
All right, now we'll take a question from the chat box.
Dr. Chu, in regards to your patients when you have non-traditional risk factors for heart disease, when we're talking about patients with HIV, is that only if they're not on antiretroviral therapy, or is this true even if they are controlled on antiretroviral therapy?
Patients with HIV essentially exist on this spectrum, right? So if they're untreated, they definitely have a higher risk than someone who is compliant with their medications, but that risk is still there just because of the disease process itself. Both of those groups will still have a higher risk compared to someone who does not have that disease.
Hello. Oh, hi. I had a question for Rohit. I actually had a patient come into Mercy the other day who was a chronic heart failure patient who always had low blood pressures. His pressure was a little lower than normal, was cool, and we ended up diagnosing him kind of with cardiogenic shock. Started him on dobutamine. The ICU did not seem very impressed with our workup. His lactate was barely elevated and things like that. But I guess my question is for these normotensive patients who you're concerned about maybe being relatively hypotensive and considering dobutamine, what is your ultimate disposition for these people, given that they're technically hemodynamically stable? If they have like a bumped lactate that isn't super impressive, if you're getting pushback, would you ever consider admitting them to the floor in general?
Good question. So probably not. I think anytime that someone's on a vasoactive like dobutamine, specifically an inotrope, that patient needs to have a lot more monitoring just in case they do need to go to an arrhythmia. And this also depends on whether you're at a community site or you're at a tertiary care site. So at a community site, someone on dobutamine would probably just end up in the ICU. At a tertiary care site, it depends on the rules. At our university, for example, you can have patients PCU, step down, or intermediate IMCU, whatever terminology you use, on a stable dobutamine level. If they're constantly increasing and they're on a stroke, then they will with the minute study 2.5, for example, and they relates to wean, and probably have them.
Follow-up question for this patient population. If you have a patient who's on like milrinone outpatient, they have it for maintenance therapy, or when they come in this state where they look slightly worse than normal, are you going to that agent and just increasing it, or would you ever like consider alternative, like instead of milrinone, use dobutamine or vice versa?
Do you mean that they're on a milrinone pump, for example?
Right, like they're. Yeah.
A milrinone pump will be a little bit trickier with filling agent that they're getting good for dose. Most of the time, because it's milrinone has a longer half-life, so you have the resources to be able to turn off for one and turn on it such that you can control the rate. After you do that, you can either just cardiology assistants titrate up, and in very rare cases, virtually refractory to therapy, then they'll do dual inotropes, but usually that's a decision that's beyond our level.
I would add to that that if you have a patient and if your patient is in on a drip already, just understand that anyone on does take much longer for and is the prolonged hospitalized as a sensitivity on it, and it has more potent effects.
So another quick question from our chat here. This is for Dr. Twalda, but I think also for our whole panel. In regards to when we're intubating our patients who have RV dysfunctions, do you guys have any advice or any like standards that you guys typically like to use when you're into types of patients?
Don't do it. I don't know if you heard me. Don't do it. I mean, there is no safe way to intubate the right ventricular patient. Very, 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 very high risk. Intubation. Optimizing hemodynamics, obviously, as you read, not only with those specifically, but all patients prior to intubation is important. But just understanding that if the patient has a significant volume load or requires diuresis, I think often people are afraid to diurese a hypotensive patient, right? But consider optimizing. Often people with right heart failure can appear very dyspneic, and it is the trigger to intubate, right? A person looks like they're worsening or they're also hypoxic, but it is a systemic venous congestion issue. And so offloading some volume, in fact, gets them better. So what I opt to do is put them on high flow nasal cannula, diurese while optimizing, utilizing depending on the left function. If I need inotropy versus just a vasopressor while I'm offloading the ventricle, meaning diuresis, so unloading the right heart and preventing intubation.
I'll add to that it depends on what the etiology of the right there is. So for example, if the etiology is a pulmonary embolism, then you need to do RV afterload reduction, which would for PE be lytics or refer them for thrombectomy. If it is a pulmonary hypertension, that becomes a little trickier. Again, you want to avoid intubating altogether. But there's a couple things that you can do. You can pre-oxygenate them. You can put in an A-line to make sure that they're not going to collapse and that you have titratable pressors, norepinephrine, epinephrine ready for them. You want to have your expert intubator do the procedure so that you're minimizing time with hypoxia. You want to make sure that you're not bagging them too much because that can cause increased intrathoracic pressure. So there are ways to do it. It's just not the most ideal condition.
I'm interested in finding out what conditions it's recommended to have a novice intubator for this condition. Of the least experienced person.
That's fair.
Coming off the street.
Dr. Feldy, not specifically about valvular catastrophes, but in your SCAPE patients who I think, in my experience, a large part have been on some approximation of GDMT, including an ACE inhibitor or ARB. When do you start to consider using like enalapril or IV ACE inhibitors?
I definitely think it's dependent on where you are, right? Like if it's an EMS colleague and they don't have other afterload reducing agents, I would say of all of the agents, the most potent agent and the one with the most evidence is going to be positive pressure ventilation, right? And increasing the expiratory pressure to make sure it's high enough, like not starting them at 10/5 and leaving them at 5. Once you get that expiratory pressure higher, not only does it help with workup breathing, but it's a significant afterload and preload reducer. More so than anything else. If you know they have volume overload, let's say they're heart failure or they have chronic kidney disease, and they have native urine function. Although Lasix, when you are clamped down, including your splanchnics, are not going to work immediately, don't forget that if I know volume needs to come off, the earlier you give Lasix, it is also a venodilator, especially earlier. The distribution of it the loop agents specifically act to venodilate. So I'm not trying to diurese them, it's just trying to give them some venodilation. All of those agents, including your nitroglycerin, of course, which should be in addition to at the same time with your non-invasive, are going to hang around and are much more titratable than the enalaprate. And so I personally don't go to ACE inhibitors because of the long-lasting effects that I've seen on people, especially on GDMT, that later are hypotensive and are holding on, hanging around, that I don't want to happen, especially if I need to diurese them and then I diurese them and then that's on board, then they get hypotensive. So I prefer things that I can titrate more carefully. That being said, I wouldn't poo-poo it. Certainly, if that's the agent you have and you need afterload reduction, right, then you're going to go with it.
This is for Dr. Chu. For our patients who come in with an EKG that has what looks like a STEMI equivalent on us, but maybe they don't have any chest pain or they have a normal troponin, do you have any advice on like how we go forward with things like that?
I think when you have an EKG that looks like that, I would not hesitate to reach out to your cardiologist and kind of discuss what you have in front of you in terms of the patient's presentation, the EKG that you have, and kind of move forward in that manner.
Okay. Thank you guys. This is about pacemakers. So if a patient, you're worried the battery is dead and you're worried that there's no capture and it's just not working, it doesn't matter if you do transcutaneous pacing or transvenous pacing. Like, does it affect if they have a pacemaker, or like compared to someone who doesn't? And then if you're worried, like if you think the battery's dead, but I don't know, what if it's not, and would that interfere with it? Would you still place the magnet? And if you do that, does the magnet then interact with the transcutaneous or transvenous pacing?
Are they symptomatic? Is going to be my first question, right? So you only treat bradycardia if the patient is symptomatic. So let's say battery is dead, which, by the way, it doesn't just suddenly die usually. There's like months of warning for the patient and beeping. So let's say they never come in and the battery is actually dead. You can either transcutaneously or transvenously pace them. Now, there are wires in their vein, so it might be a little difficult, but you still can introduce your transvenous pacer. So I would start with transcutaneous. Your second, or the second part of the question was, if I put a magnet on it, would that interfere with the other one? Yes. I don't know. I actually don't know how, if anybody here knows, but I don't know if it would, because the machine itself is external, right? If you have your transvenous pacer, let's say. I don't know to what extent it's going to affect it, but what, the battery? If you're saying if I'm not sure it's dead, if you put the magnet on it, it should tell you if it's dead or not, right? If you put the magnet on it and it works, then it's not dead. If it doesn't work, then the battery is dead. Yes. Yeah. 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 But the next time we have a patient, we can try that. We can put the magnet on and see.
That's a good question. I don't have a good answer I don't think a magnet should interfere with with an external or a transvenous. The way that the magnet works is to actually, there's an internal switch that switches it to asynchronous mode on the actual pacer device. So I don't think externally, externally by pacing pads or internally by a TVP. That being said, it might be a little bit harder to float the TVP. Almost all of them are left subclavian access. So then if you imagine the wires going down, you might just have a little bit of difficulty the catheter into the RV.
What happens?
I don't know what that, yeah.
I would also add you can use epinephrine, right? In the event that you are, I mean, obviously it takes time to get your transvenous pacer on, or I'm sorry, transvenous pacer in. And let's say transcutaneous pacing is not working because of body size habitus, for instance. Um, Agreed with what Rohit said. Like the magnet itself does not preclude you from pacing. You can pace. But what you can also do is give epinephrine, right? Like start an infusion if the person is hypotensive or symptomatic while you're getting those other things that take a lot longer. You have often epinephrine, right, at the ready.
Then one other thing, in practice, if someone is getting transcutaneously paced and then we put in a transvenous pacer, we, in practice, turn off the transcutaneous pacing and then turn on the transvenous pacing. But since they're sensing the rhythm of the heart, they should actually be synchronized. So you can leave the transcutaneous on at a lower voltage and then turn it off to just make sure that you're actually getting electrical and mechanical capture with your TVP.
I'm just going to add one comment. I would say that before you ever decide a pacer's not working, consider hyperkalemia. That all too often that transvenous pacers don't work because the patient's hypercal. Was mentioning during the lecture, there's a case go, and then another one on I think the 14th or 15th. Came in with a heart rate of 30 and pacing, pre-hospital pacing wasn't working, and
Another question from the chat for Dr. Matu. Have you ever seen like accelerated atrioventricular rhythms be anything other than reperfusion rhythms? Anything that we should try to treat? And sort of going along with that, do you do you have like a personal opinion or anecdotally, do you feel like it's the most unrecognized EKG pattern that leads to like diagnostic delay and morbidity and mortality in real world cases?
I don't think it's the most commonly missed tachytus or missed arrhythmia because it's not that common. I think probably AFib. If you see something that looks like slow vtac or vtac, but it's just really slow, or that can occur because of thrombolytics that you gave, but it can occur just through spontaneous reperfusion, where patients coming in and they just reperfuse on their own. So you may see it even though you didn't give any drugs. And again, it's going to look like VTAC, but it'll be too slow. In those scenarios, there's no need to treat. You just kind of wait. The rate is never fast enough to cause instability. That rhythm does not cause instability. They also see that rhythm peri-arrest or post-arrest. We'll see it oftentimes after you get return of spontaneous circulation, and then you'll see a short run of AIVR. The last thing you want to do is to suppress it because that'll turn it into asystole. So just shock it. You don't need to give the or amioprocainamide. Just on it, and usually it's going to go away. The one other comment I might add is that oftentimes comes up is are there any scenarios where you could see VTAC at a slower rate? And the only time I would say that you could ever see VTAC at a slower rate is if you see somebody who is chronically on oral amiodarone or oral flecainide or oral propafenone. Those patients may have true VTAC at a rate of 100 or 110 or 100. Pretty rare. We don't see too many patients chronically on oral meds like that. But that might be a scenario where you'll see true VTAC at a slower rate. Again, that will not cause instability, not get instability from any type of rate of 90 or 100 or 110, even if it's ventricular.
I would just add we're talking about vtac. So remember, like a slower rate in a person with structural, again, valvular heart disease, like let's say aortic stenosis, that has a AFib at 110 could be catastrophic and may need to be cardioverted. So again, lower rates with structural lesions definitely warranted. I did have a question earlier. I don't think this resident is still here, but about the category I mentioned about dynamic left ventricular outflow tract obstructions and how is the treatment different than the treatment we discussed during my lecture. The treatment, just to let everyone know, I think that was a question, is usually a little bit of volume. And these people, unlike people with regurgitant lesions, require beta blockers. And if they're hypotensive, pure alpha vasoconstrictors. So we're talking phenylephrine, vasopressin. And if you remember that mantra, that's how we treat stenotic lesions, right? Stenotic lesions, usually it's beta blockers, pure alpha, and supporting the ventricle, meaning volume, not diuresis, which is the polar opposite of how you treat regurgitant lesions, which is afterload reduction and diuresis.
Because there's a little bit of overlap between our presenters for this question, but for ACS and patients with pacers, particularly those classic, just the right ventricle pacing lead, we're taught to use modified Scarbosa criteria to help make that diagnosis. In the age where the electrophysiologists are refining their placement of those leads and also using the biventricular pacing devices, how should we go about figuring out ACS presentations in those? Yeah, so my understanding is that the biventricular pacers are becoming more common, so are different placement by the electrophysiologist of the pacing lead. There it is in the ventricle. How that would reflect, how that has implications on using modified Scarbosa criteria.
So the EKG wouldn't look like a left bundle branch block? You're saying if it's just the left ventricle that's being paced, so you have a right bundle branch block pathology on the EKG? Is that what you're saying?
Yeah, that's my understanding of the purpose of the biventricular device, is that there's better synchronicity between the two ventricles being paced.
So that's a great question, and it's becoming a common issue. So everything that Eileen had talked about with the Scarbosa criteria only applies to patients right ventricular pacers, bundle pattern. But with the new biventricular pacers, patients don't typically have the classic left bundle pattern with the deep S waves in V1, big R wave in lead 1, and so on. So biventricular pacers will not give you a left bundle pattern. Therefore, you cannot apply the Scarbosa criteria to biventricular pacers. There are no criteria for biventricular pacers. Intuitively, what you could probably use is this thing of discordance. So with any type of pacer, when the QRS primarily goes up, there should be ST depression. Where the QRS primarily goes down, there should be ST elevation. That should apply for biventricular pacers also. So with a biventricular pacer, in any lead, if you see the QRS primarily go up and there's ST elevation in the same direction, that's bad. When the QRS goes down and there's ST depression in the same direction, that's bad. And I would worry enough if I saw that in any lead to call cardiology. Could get pushback from cardiology, and they could reasonably argue, well, there's Scarbosa criteria don't apply there, and then you're kind of stuck just following troponins and following the patient. But I would worry if there's loss of the normal discordance. Go with the biventricular pacer. Question?
This is also for Dr. Matu. Do you give for everybody who has prolonged QT magnesium, and if not, what are your triggers for giving them magnesium?
I have a low threshold to give magnesium to people with a prolonged QT while I'm waiting for their electrolytes. That doesn't mean I give it to everybody. I don't want to be dogmatic, but I would just say I have a low threshold. The people in whom I would worry about empirically giving magnesium are people with renal failure because they can develop hypermag. somebody doesn't have renal failure and I see a long QT and for whatever reason I'm worried maybe there's already throwing some PVCs here and there, I'll give them a couple grams of magnesium while I'm waiting for the lights to come back. And then once the electrolytes come back, then you should know for sure exactly what you need to treat, whether it's hypoK or the long QT is primarily due to the ST segment. I might empirically give them a gram or two of calcium.
Sort of going off of that, if you have a patient who has like a bradycardia that's not responsive to your trans pacing, would you consider like early administration of calcium before you moved on?
So with bradycardia, especially if they're unstable, the algorithm usually goes, you start transcutaneous pacing simultaneously with epinephrine or atropine. More studies are pointing towards epinephrine because atropine is only a vagolytic. I would start them both at the same time. Additionally, if there's no good response, then always keep calcium bicarb in your back pocket because hyperkalemia can definitely cause bradycardia that doesn't respond to either transcutaneous pacing or atropine or your usual treatments. So yes, my answer is if it doesn't respond, then I would give calcium. Any other thoughts?
Couple questions for you guys. My first question, I guess, is for Dr. Matu. You showed a couple different morphologies of QT prolongation and mentioned hypokalemia, which I'm now terrified to miss in any of my vomiting patients. Sometimes with hypokalemia, you see these U waves. I was wondering where that kind of fits with your QT prolongation because it's QT, and I don't know if that where that kind of fits with things.
All right, so with technically, if you want to be a purist, hypokalemia does not prolong the QT, right? Hypokalemia only appears to prolong the QT because what you're actually getting is T, and it just looks like a prolonged QT. So if you're talking to a purist, what they will say is hypokalemia doesn't prolong the QT. Tell them go get a life. I include hypoK in my differential because whether it's true prolonged QT or TU fusion, either way, the patient's at risk for torsade. And so when I'm trying to figure out, does the patient have a prolonged QT or not? Do I need to worry about torsade or not? I do include the U wave in that measurement because if there's a big U wave, that person is still nevertheless at risk for torsade. And really, that's all I care about. I don't care about, honestly, I don't care about the QTC. I just care about torsade and the something long that's going to predispose to torsade, then I'm going to put that in my differential. So in terms of the U wave, yes, I do include that in my measurement, and your computer oftentimes will as well.
Next question is in regard to cutting pacer wires. Is that like a trauma shear 10-blade kind of thing, or like where are we going with that?
Teeth. I believe it's teeth.
Or teeth. I like that. Try teeth. Anything you have. So pliers works. I've never tried trauma shears, but let me know how it goes. Anything that can cut wire, I guess.
Final question is there any patient that comes to the ED these days that I should not be getting an EKG on?
Knee pain.
Unless they had syncope and fell and hit their knee.
Oh, that's true. Yeah, you're right. Wrong.
No, it's a good question, and we do have a very low threshold for checking EKGs. I'm oftentimes surprised that EKGs are obtained for wacky reasons. I think that every test should be obtained if there's a reasonable suspicion for it. And so I don't want to see EKGs on patients in whom an EKG. All you're going to end up with is a test that the patient gets a bill for, and oftentimes it's abnormal, especially if they have chronic hypertension. They always have abnormal EKGs. And now you're stuck with an abnormal EKG with a history that doesn't fit. What are you going to do with it? What if you see some ST elevation in some leads with ST depression in other leads, which is brain, and the patient, what am I going to do with that? And the patient doesn't have any real cardiopulmonary complaints. So do I need to keep them there and check troponins and get a repeat EKG and so on? So I'm not a fan of getting EKGs on everything that walks, believe it or not. I think that there should be an indication for it. I have a relatively low threshold of indications. Eileen talked about some of those atypical presentations, but tends to get it, then just don't get it. Don't, you know, don't ask questions if you don't know what you're going to do with the answer.
Again, from my personal experience, there was a patient who came in with a bee sting to the arm. He said he was swarming outside, and then his left arm started hurting, and he thinks it's a bee sting, and I couldn't find the actual bee sting. And when I asked him more questions, like, yeah, I was working for like 3 hours, and then now my bee sting, I'm a little short of breath. It was a STEMI, right? So like elbow pain or like, bee sting, get us that, a couple of weeks ago, I had a patient who was sent in to rule out a dental abscess. She was 75 years old, and she says, my jaw hurts, so they said I have an abscess, so come, I need to check it. I need a CAT scan. But no, she didn't have an abscess. It was radiating chest pain to the jaw because she's 75 years old with ACS. So again, get a
In other words, do a good history and physical. And also, people don't get these things in Maryland.
Sort of along those, uh, for our patients who come in with like those regular complaints, like, oh, I feel anxious, or I feel really tired, or I'm just like a little nauseous. Like, what is your threshold to, if you EKG is normal, to like get a troponin or something on those patients?
Again, it all comes down to getting a good history, physical exam, assessing for what risk factors they are and what you're actually seeing on that EKG. If that EKG is completely normal, they're still having symptoms, maybe you consider repeating it. Unless it doesn't fit, I would not get that troponin.
This is for Dr. Manon. For chat, cited that there.
So the question was, can you use a peripheral oxygen saturation to correlate findings of cardiogenic shock with central venous gas? And I think the answer is no, as you can have a good peripheral sat. You see patients with cardiogenic shock or any shock who might have a sat of 92%, 93%, but that doesn't mean that their mixed venous gas, their VBG peripherally is the same. I don't think I would rely on a peripheral sat. If they're talking about a peripheral VBG versus a mixed venous sat, then I think the answer is still not really, because the peripheral VBG will not account for a mixing of the blood that you would see all of the upper venous vasculature in terms of a central venous set, or a upper and lowers in terms of the true mixed.
And then just one final question for Dr. Matthew here. Let's say that I have a patient come in accelerated AV ventricular. I don't recognize that, and I do give them kill them. Uh, can I give them a bunch of bicarb to like reverse that? Can I bring them back that way?
First thing I would do would be to contact risk management. So it's with AIVR, it's not a sodium channel issue, and so giving bicarb to that patient probably is not going to help. The best thing that you could do would be to start and give epi and hope that you can get that means. If you were to change that question to, say, hyperkalemia mimicking vtac, and I gave that patient amiodarone and I put them in the ACEs degree, can I give a bunch of bicarb and bring them back? I think that is possible. I think there's a better possibility because the bicarb might reverse what sodium channel blocking effects you hurt by giving it. AIVR, I think put them into asystole, compressions, and epi, and normal ACLS is all you could probably hope for.
I think that wraps up these three questions here in the room.
Right. Now that our tech difficulties have finished, our program is also finished. We'd like to thank everyone for joining us so much. I thought to do this at the end of the program was thanks to everyone behind the cameras that you cannot see, including our department leadership who helped host and fund us to put on this event. Our program coordinator who is outside, I think, having a seizure because of all of the problems we've had with tech. And again, we apologize to everyone who, again, you guys can't see, a big thank you. And I think the gods are punishing me for not thanking them earlier enough in the program. Russian hackers is what I was told. But we hope that you have taken something that you can apply to your everyday care, and we hope to see you at our 11th annual. Hopefully, it's still happening after all these tech issues. I hope you don't veto us off. Cancel culture, I think that's what it's called, but we hope not. And stay tuned for our upcoming critical care symposium coming, I believe, in 2 months. So it's a pleasure to have you guys. And again, thank you very much for your patience. Have a good day.